I'd particularly like to thank John for giving new value to my undergraduate chemistry degree. I always wondered why I did that. So we have about 25 minutes or so. I know Mary's going to have to leave a little bit early, so if you have questions for her, you might also be thinking about those. But maybe just as a lead off, a constant theme that came out from all of you, both in what you modeled, but also what you spoke about, is this aspect of leadership. But a somewhat different kind of leadership than necessarily leading within an organization when we lead across organizations. And I think we all kind of have been raised on the 80-20 thing, and we tend to focus on the 80 and forget about the 20. But the reality here is you have to pay attention to both the 80 and the 20. And part of the opportunity is to think about where are the efficiencies, the scalability for the things that can be done consistently, the 80% that we can actually specify. But what are the 20% where we need to be adaptive? And are there thoughts about, where are the efficiencies as we think about how we set up these networks that we really shouldn't be doing duplicatively? And the argument would be also that's the only way we're going to have the capacity to be adaptive for the other 20%. I'm just curious if you have thoughts about how we can think about where we can expect to specify, but where do we need to back off and be a little more adaptive?
I do think one of those areas that makes much more sense, both because it is a good collaborative opportunity, but also because it's a work in progress, is clearly in the area of measurement. And so we're maybe first or second generation in our measurement development on lots of things, and our ability to do that work together will be, I think, both more effective and have a greater likelihood of affecting system change if we do it together. I still think too many times competing measurements stand in the way of progress.
Both Kaiser's National Research Council and the HMO RN Governing Board are actually weak organizations that control little money and virtually no decisions. And so if you look at the sources of innovation in our networks, they've really arisen from individual scientists or from scientific teams. And I think that's where my sort of message about not over-governing a network really comes from, is that to be alert to the real sources of breakthrough innovation, you need to learn from, much as we talk about learning from organizational leaders and learning from patients, in a scientific network, you need to learn from the scientists and not sort of impose rules and order where they're unnecessary.
So we don't exist in a vacuum, and I think one of the things that we are looking at is, as the federal government has unfortunately Nancy's left, but meaningful use rules and other sort of pay-for-performance sort of measures, we're looking at, is this a distractor? Is it taking people away from what we want to do, which is incent people's intrinsic motivation to do this stuff, because if they do it, there's mastery, purpose, and autonomy built into it. And I think that's the weakness, as I've heard reward systems trying to be set up for patients, for example, to reward them with money or lower copays or things like that to do the right thing, is that the educational research has shown that if you take a human and you give them money to stop smoking, as soon as you quit giving them money, they'll start smoking again, because you haven't really changed the underlying parameters. And I think unfortunately, many of us who are designing these research projects and other sort of things to get patients engaged have big prefrontal cortexes, and we understand delayed gratification, and sure, it worked for us, it should work for them. And I think that the comments that were made before about there are different cohorts of patients, and so as we're looking at institutional goals to align what we're doing to make it better for patients, I think we are finally coming to the realizations, patients decide differently. And how do we know what populations we're dealing with? Because waiving copays and doing something for certain populations, and they may be the 20% that are using most of the resources, isn't going to be effective, and we're going to have to have dual designs of implementation on some of this stuff as we're trying to influence individual human behavior.
Great, thank you. Well, we can open things up for discussion and questions if folks are now shy. Al.
I'd like to push the conversation around governance or around data a step further, because mostly I live in the research world. We collaborate with various people, and we're pretty good at doing that. But I'm also aware, and obviously with the release of the Medicare claims data, other pressures for transparency, there will be more and more data of highly varying quality. And I remember when the first Medicare mortality data by hospitals came out, the clincher was a hospital administrator in Nevada having to explain an 85% mortality rate. And he said, I'm actually surprised it was so low. We're a hospice. And so it was a misclassification, and some patients obviously left before they died. There will be a few of those, and the quality of the data will be sullied. Researchers are good at worrying about quality of data. But the part that I'm getting to, and I sort of wish I lived in Minnesota where organizations that compete with each other could actually share data and look at performance. But one of the questions that I see coming up here is data governance where organizations are at risk because of the findings, not patients. And how does one manage that level of governance? And we might think a little bit back to the previous panel. There is a nice mechanism right now with respect to every time I go to the IRB or every time one needs a data use agreement, you have to explain what the purpose of the study is going to be. So even if we're sharing it, you have to go through that, and that does not give somebody leeway to go and look at it any way they want. The newspaper report of health services researchers do not have to sign those DUAs. And so I'm wondering whether that might lead to some governance opportunities so that data can be shared, looked at carefully, but organizations not inappropriately put at risk by somebody who is just out to get them for some reason, the hospice with a high mortality rate.
Well, I can at least give the example of the data sharing that we've done in Minnesota that's publicly released. Actually didn't start from scratch releasing a report publicly. We started with years of shared measurement development where maybe the HealthPartners way of measuring was accepted for one but not used for another measure. So we had to give up control. We truly had to be transparent about how we were measuring. We committed to a year. So we develop a measure, actually get the data, and we committed to a year of not publishing any specific measure until we'd had a year to work with it. So the track record of giving all of the institutions, so these are largely institutions who were at risk, and right now from a health plan point of view, I think about 85% of our members are served where we have risk or value-based payment approaches, so their dollars are at risk. And so I think it was that track record of time, transparency, building trust, and being willing to let go of some control that has paid off.
But just to clarify, you've not given those underlying data sets to somebody else to analyze in different ways.
No, at this point we have not. We haven't given, we've given our data to Minnesota Community Measurement, but we haven't handed it over, for example, to the state of Minnesota, who would like to have access to that same data to do whatever the state would choose. We've actively, it's been delicate to keep that from happening.
Yeah, I think there are some key boundary areas that are going to evolve where in networks there's going to be the opportunity to both share what are the learnings about those boundaries and how to manage those boundaries. And so I think one of the real opportunities is to not have that just be one-off, one organization at a time, if in terms of governance.
Yeah.
Yes.
But I wanted to comment on Jim's presentation about the high-value healthcare collaborative work. I mean, there definitely is risk in that space for our organizations. We're going to be publishing at the institutional level our cost of care to Medicare and to some extent some measures of clinical outcomes and processes of care. So I think that's one of the things that we need to recognize when you're talking about research and improvement at the organizational level or system level, and you're committed to transparency, there's absolutely risk there. And there's, if you look at the distribution of performance, there's some high-value healthcare collaborative organizations that are probably a little uncomfortable about their hip or knee data being in the New England Journal of Medicine. But I think that's part of what's involved with playing in this arena.
And to follow up on that, just to give the Medicare dump data, doctor dump data as an example, the difference is that data has been shared internally. It's cleaned up. Everybody gets to look at it. You know you're going to be good or bad. You know where it is. Whereas the Medicare claims data, there was no sharing with the physician community a week ahead of time to say, take a look at it, either look at it or not. Give us your feedback. Let's kind of get it comfortable before we release it. And I think that's the governance issue of saying, are you out to get that there's bad people and this is the way we're going to do it? Or is your attitude, look, no data is perfect, so let's kind of work together to try and figure it out and try to do it in a different way. And I think that's going to be a very important policy decision on governance as this whole transparency initiative continues out is what's the purpose? If it's the old quality assurance, right? There's bad people out there, this is the way to do it. I think you're going to find we're not going to accelerate as we want because then people are humans and they're going to do what humans do, and that is stay away from people that are beating them with sticks.
Yep.
Hi, Russ Whiteman, University of Kansas Medical Center. This has been a great discussion. I loved your slides on data governance because that's really practically been very helpful to us in our fairly new network across the central time zone. So as much as, data, basically there are two main things I've heard coming about what we're going to do with the CoreNet. One is we'll support observational types of studies like HMO Research Network, and the other is we're going to do trials and pragmatic comparative effectiveness research. And as I've thought about this throughout the course of today, the QI model has not really been discussed much as a part of the PCORI mission over the next 18 months, but it seems like the consensus of the discussion is that QI model is actually the more sustainable model for the health systems that we are supposed to interact with. So I want people's thoughts on that, and especially around governance, because it's fairly benign. I've worked with our hospital with Marilyn Reimer, to basically give me your data, trust me, I'm going to put it all together for research, and it's not a high impact upon the healthcare system at all. But when, like Dr. James was saying, if you want to start doing interventional trials, and I've got a QI viewpoint when I'm running my healthcare system, how we govern and reconcile that, I think is going to be a real key challenge. And I'd love to hear what the panel thinks would be good solutions.
Well, I think one of the observations is that PCORI is young, it's new, and it hasn't figured everything out yet. So if the one thing that happens from this is they redesign PCORI.net, then obviously this workshop has been valuable to them. So
I think, there's been some research about the acceptability of interventional studies to healthcare delivery systems, both at whether individually randomized or group randomized, cluster randomized. And I think there are some messages about how to make those discussions go better. I think one of the first precepts really is don't interrupt clinical workflows. You know, stay out of the way of people who are running as fast as they can. And so it adds the need for some, I think, ingenuity in study design. But the less the disruption, the more likely it is to get that sort of top level buy-in. Now, like anything else, that's not an absolute, and there's sometimes where disrupting the clinical workflow is exactly what you need to study, I recognize. But I think the principle of co-designing interventions with the people who have to carry them out and the people who have to really live with the consequences, not just of the findings, but of actually doing the research is pretty important.
So you would see a co-design type of governance as being necessary for our CDRNs to be creating?
Well, yeah, I think so. I think, we and I think most research organizations have taken ideas for interventions that we are just so jazzed about to our leaders, and they just simply say, when they're polite, you must be kidding. So I think approaching the rest of the organization with great respect is critical. But on the upside, essentially what it forces you to do is to design for sustainability. If you do an intensive intervention that can't be sustained, what have you really learned? Whereas if you design an intervention that might be less efficacious, but that integrates with a clinical workflow, the likelihood that it'll be sustained and that the net health value will be higher is greater, I think.
I might point out, making the right thing easier has been a QI mantra for about 25 years. But there's also a corollary that's been learned a lot in QI, is that if you make it easier, it damn well better be the right thing. And there are a lot of errors that have happened. So I think actually the ethics discussion earlier was a really important one about recognizing that there's a lot of well-intentioned stuff that's been done in the QI space and has been facilitated that didn't work out that well. And that there's, so one of the other reasons to think about how QI offers learnings is to think about what's been done to try and avoid what's been learned within the QI world about things not going well.
Go ahead.
I sat on a WellPoint Anthem Hospital Advisory Panel for their QHIP, which are the measures that they apply for pay for performance incentives. And so there's a big dialogue that they had about using STS data as kind of a national standard. They brought in the folks from STS, and there's a lot of pushback from different hospital systems about the data and the lack of an audit process. So if we keep tying more money and more incentives to quality metrics or use as standards, yet there's no and they're reputational, have reputational importance for the organizations, yet there's no, assessment. I think I have some worry. The core measures, for instance, which form the basis of many ratings and rankings, at least are auditable, and there's large penalties associated with inaccuracies of the data. Have you thought about, the issue of data accuracy?
Let me answer that STS issue, because I think this is a good example where the medical profession came together to measure themselves, funded it themselves, and got the thoracic surgeons to buy in because this was quality improvement. And it got co-opted by the payers as a pay for performance. It wasn't designed for pay for performance. It wasn't supposed to be pay for performance. So the pushback you're getting from the medical profession on some of these issues is that doctors don't need to get paid to do the right thing. Just give us the data and we'll do the right thing. We've been doing the right thing forever. But when you denigrate the medical profession to say, well, doctor, the only way you're going to improve is I'm going to give you money to manage that diabetic, then the professional pushback is, oh, the hell with you all. So there needs to be I think the dialogue on this relationship of pay for performance, pay for value, quality improvement, the professional ethic, which was talked about in a couple of the, I mean, the reason that doctors became doctors and the reason nurses became nurses is we want to care for people. Give us the information so we can care for people. Don't hide it from us, but then don't impugn us that the only reason that we're going to do something better is you're going to give us money. I mean, yeah, I mean, give us the right data and we'll deal with that. So I think that's the struggle that we're seeing now as the acceleration of the payers and everybody else is saying, well, the only way that this is going to happen is we're going to, bang them over the head. I think now, did pay for performance accelerate the research on what to do with MRSA? Sure it did. But once it's out there, then people adapted to it fairly quickly because it really was the right thing to do. And I think that's the ethical professional balance that we have to keep never losing sight of, that if we keep driving, the only way we're going to make change is by giving people money, that is that extrinsic motivation will suppress the intrinsic motivators that really are what's going to make healthcare better.
And I'll address your question from the other perspective, which is really, the answer is we think about data quality obsessively, basically. And because we're trying, our commitment is to generalizable knowledge, replicable findings. And there is a whole, didn't have any time to talk about it, but certainly within Kaiser's Caesar data network and the HMRN, there is a whole architecture of data quality measurement and improvement that consumes enormous amount of time and resources from some really talented people. And I will say that the end product of that is a research data warehouse that actually is an unexploited organizational asset, is that we have data that aren't perfect, but are substantially cleaner in most regards than the data sources that operational clinical leaders use to make decisions every day. And I think one of our conversation points with our organizations is to try to essentially determine how our research data warehouses, for a subset of the questions that operational people will ask, can actually become enterprise data resources as well.
So I think we have time for one last question. So Susan?
I wanted to echo how much it mattered to the Reduce MRSA trial, the practicality of QI. I made some denigrating remarks earlier to be provocative, but the truth is that of our entire steering committee and our co-investigators, I think all but our statistician and one of the microbiologists were clinicians who were actively practicing and in charge of hospital infection prevention programs. And even though I didn't mention it, it was in every thread of every protocol that we developed. And all the things that we threw out were things that we knew would never normally be put into common practice. And so I didn't even think about it. It was so ingrained in the way that we think that I didn't even think to mention it. But I think it's a critical part of pragmatic trials, is not just bringing the patients to the table, but we need to make sure that the people who would implement are critically part of the discussion from the beginning, so that it's not even an afterthought. It's just part of the integration of doing a right trial, is how easy it is to flow and disseminate.
Well, great. Comments? Well, I guess the one comment I'd make, and I think someone made this earlier today, is that I think we've demonstrated that as we increasingly think about how we can use networks for research, there's also a lot of opportunity to do research on networks. And, we have some insights, but I think that they're not fully developed. And so I think as we look for where there are fertile fields, that's going to be one. So I hope you'll join me in thanking the panel.